this point in time in 2019, first-line treatment for metastatic colorectal cancer is still mainly chemotherapy combination plus a biologic agent. And we've learned a lot from 8405, the large US intergroup-based study, which compared chemotherapy backbone, either FOLFOX or FOLFIRI, plus either cetuximab or bevacizumab, which initially did not even have a KRAS mutation analysis incorporated in the study. But in 2008, when we learned about KRAS and later all RAS, the study was changed to really refine the patient population that we considered eligible for EGF receptor antibody therapy. And only patients with KRAS wild-type tumors were included in this randomization, cetuximab versus bevacizumab. We've learned actually several things. First of all, the overall study did not show a difference in survival for cetuximab or bevacizumab-based treatment added to mainly FOLFOX in the United States. But then when we refined the analysis, did post hoc analysis, eliminated patients with NRAS mutations, BRAF mutations, and then looked at the sidedness question, left versus right-sided tumors, became clear that patients with left-sided RAS-RAF wild-type tumors, they actually do benefit from cetuximab in terms of overall survival benefit over bevacizumab. So right now, I believe, that for these patients, probably 20, 25%, 30% of patients with RAS-RAF wild-type left-sided tumors, EGF receptor antibodies like cetuximab and panitumumab would be the standard of care. On the other hand, we also learned that for right-sided tumors, even if they are RAS wild-type, cetuximab did not work. Actually, there might even be a detrimental effect, which has influenced guidelines. So for right-sided tumors and for all the mutant, meaning RAS mutant tumors, we definitely use bevacizumab as first-line therapy. Now, the emerging data that we might have to look at molecular profile patients, HER2-positive tumors, MSI-high, BRAF, V600E mutant cancers, and those patients might be better treated in first line with targeted approaches, but that's something that's still being tested in ongoing clinical trials.
Treatment of metastatic colorectal cancer has been changing a lot in the past 10 or 15 years. In particular, if we have to consider which is the role of biologic agents in first line and the role of anti-angiogenic drugs and anti-EGFR drugs in first line in combination with chemotherapy, we consider that the FIRE3 trial has been a pivotal trial to illustrate that although both combinations are a very good choice for the patient, in terms of overall survival, especially for patients with RAS and RAF wild-type tumors, and especially those patients whose primary tumor is located in the left colon or in the rectum, the preferred choice should be chemotherapy. In the case of FIRE3 trial was FOLFIRI, together with anti-EGFR monoclonal antibody, in this case cetuximab, because this combination was better in terms of overall survival as compared to FOLFIRI plus the anti-angiogenic drug bevacizumab. So from the FIRE3 trial, we can conclude in RAS and RAF wild-type patients, a preferred option, especially if the tumor is located in the left side of the colon or in the rectum, should be FOLFIRI plus cetuximab. Okay, the FIRE3 was a study in which patients were treated in first line with the same chemotherapy backbone, so the doublet FOLFIRI, because FOLFIRI's doublet was relatively high popular in Europe as compared to FOLFOX. In this case, the comparison was between FOLFIRI with bevacizumab versus FOLFIRI with cetuximab. In terms of response, the number of responses and the deepness of response and the quality of response was higher in the FOLFIRI plus cetuximab arm, whereas in terms of median progression-free survival, there was no major difference between FOLFIRI plus bevacizumab or FOLFIRI plus cetuximab in this trial. Although there was a clear advantage in overall median survival that was clinically significant in patients that received in first line FOLFIRI plus cetuximab. And as I said before, this is particularly evident for those patients whose primary tumor is located in the left side of the colon. That is about 60 to 80% of patients with metastatic colorectal cancer.
When we look at the landscape, genetic landscape or genotyping landscape, genomic landscape, before we actually think about treating a patient, in my clinic, I want to have RAS, BRAF, so not just KRAS, I want to have NRAS, HRAS, which is incredibly rare, may not matter as much, but if it's there, we'll think about it. A HER2 amplification, whether it's present or not, and then BRAF mutations if there is RAS wild type. And then decidedness will matter as well to help us decide. So if we have a left-sided tumor, we're going to start with the one where there may be a little bit more of a discussion between the two. If I have a RAS wild type tumor that is also BRAF V600E wild type, and HER2 is not amplified, and the reason why I emphasize HER2, we haven't done that as much over the last few years, but more and more it has come into play in the decision-making process because HER2 amplification may indicate resistance to EGFR inhibitors. And it makes sense. They're part of the same pathway. One goes up when the other one is suppressed, and it may drive resistance. So there's a reason to think why this may be happening. And then I want to know MSI high, and I want to know the presence or absence of a net rank fusion, which is incredibly rare. But I think it's worthwhile to know this from the get-go. The MSI high is certainly important. I think for some patients, if there are no issues with reimbursement, I would actually favor in the presence of MSI high, starting the PD-1 inhibitor in the first line. So let's assume that I have a patient with a left-sided tumor, RAS wild type, BRAF wild type, HER2 non-amplified, MSS, and no NTRK fusion. So what do I do with this patient? This is the patient where the question of EGFR versus VEGF inhibitor comes about. As I said, the data may favor the EGFR inhibitor plus chemotherapy instead of the VEGF inhibitor, bevacizumab in this case. EGFR inhibitor could be either cetuximab or panitumumab. The problem comes from, we have two studies, one from Europe, FIRE3, and one from the United States, CLGB 80405. Both studies actually failed in terms of reaching their intent to treat primary endpoint. So those were negative studies. So we actually have been trying to learn from these negative studies, and so caution should be always exercised when studies end up being negative and we try to draw too many conclusions from subset analyses. But what may seem to be consistent in the two studies and in other studies where this has been explored primarily retrospectively, that EGFR inhibitors may have a trend. In one study, FIRE3, it seems a solid trend. In CLGB 80405, it's a small trend, not very solid, I say, because the comparison of right versus left was not necessarily something that was pre-planned. What becomes apparent is that for the patient that is willing to go through an EGFR inhibitor after discussion of the potential side effects of both, the marginal benefit, if any, again, unless we randomize prospectively and solidly, it's difficult to come up with the answer, then that patient may receive an EGFR inhibitor. For most patients in the US, we still primarily proceed with a VEGF inhibitor first. And if you look at the NCCN guidelines, they reflect the lack of preference for one versus the other because essentially the data is somewhat convincing but not solid. On the right side, it's straightforward. I just don't use EGFR inhibitors in the first line. That's a bevacizumab patient. RAS mutation, BRAF mutation, HER2 amplification, I'm going to use a bevacizumab in the first line. I'm not going to use an EGFR inhibitor. So really, the discussion is for I think about 20% of our patients where I'm thinking about a VEGF versus an EGFR inhibitor. For most, I don't.